Hello, my name is Colleen Sheridan, and I'm going to be presenting a case report on a patient with incomplete paraplegia and concurrent non-small cell lung cancer. As a brief background, incomplete paraplegia is when a patient has intact upper extremities and impacted trunk and lower extremities with motor and sensory function to some degree below the level of injury. However, incomplete paraplegia can have significant variation in presentation based on their level and grade of injury. And I wanted to talk about how there's about 18,000 new spinal cord injury cases every year, but only about 4% of those cases are actually related to medical conditions and surgical procedures. The remainder are typically due to traumatic causes. To review non-small cell lung cancer, it's the most common type of lung cancer, about 80 to 85% of cases. There are three main subtypes: adenocarcinoma, squamous cell, and large cell carcinomas. The main signs and symptoms include persistent cough, shortness of breath, wheezing, and fatigue, and treatments typically include chemotherapy, radiation, and/or surgery. Taking a look at the patient case, this is a 62-year-old male who began experiencing increased low back pain and paresthesias, resulting in presentation in the hospital, where they discovered that he had a thoracic arteriovenous fistula and concern for cord ischemia. Due to this, he underwent a lumbar laminectomy and an AV fistula clipping, and after the surgery was found to have a T8 Asia D spinal cord injury. His hospital stay was complicated by bilateral popliteal vein DVTs, and he is now status post an IVC filter placement. As a result, he was also diagnosed with COVID-19 infection near the end of his acute hospital stay, and continues to have a positive COVID-19 status at his presentation at acute inpatient rehabilitation. His past medical history is significant for current right lung non-small cell lung cancer with lymph node involvement that is status post recent chemotherapy and immunotherapy. He has a history of BPH, anemia, and a pulmonary embolism, which was within a month prior to his hospitalization. He is currently retired and lives with his sister and brother-in-law in a two-story home with 8 steps to enter and a stair lift to the second floor. And based on from his cancer treatments, they had already acquired a hospital bed, a transport chair, a rolling walker, and a single-point cane. Looking at a review of systems, he currently has spinal precautions, no reports of numbness and tingling, and occasional low back pain that he describes as aching. He's on 2 liters of supplemental oxygen via nasal cannula with reports of shortness of breath upon exertion and all functional mobility. And he also has a stage 3 pressure ulcer on his coccyx, which has resulted in a 5-hour twice-a-day sit restriction. Based on his history and review of systems for this patient, I significantly expected that this patient would have decreased cardiopulmonary endurance, decreased activity tolerance, bilateral lower extremity weakness, sensory impairments, and impacted static and dynamic balance. Based on his spinal cord injury level and grade, I anticipated him to already be at an ambulatory level with his systems, and that he would achieve independent ambulation, as about 97% of patients with HD spinal cord injuries achieve 10 meters of independent ambulation 1 year post their injury. And then looking at his cancer diagnosis, recent treatments, current COVID-19 infection, and the time that he spent in the hospital, I anticipated that decreased endurance and activity tolerance would be his greatest limiting factor at that time. Taking a look at his initial evaluations, his vital signs were all clear, and his SpO2 remained stable throughout, with reports of shortness of breath as we were doing functional activity. He had no significant postural impairments. His light touch was actually intact for all dermatomes in both of his lower extremities. He had intact reflexes for patellar and Achilles. He had decreased proprioception, particularly at his great toes and ankles, and then it was normal at both of his knees. He has heel to shin and toe taps to take a look at his coordination, were both within normal limits. He had passive range of motion on both lower extremities that was within functional limits, and his manual muscle test scores for all major muscle groups was grossly 4 to 5 out of 5 for both of his lower extremities. Taking a look at his functional mobility, his bed mobility was at a supervision level and required verbal cues to maintain his spinal precautions. He was at a min-assist level for almost all other functional mobility, particularly needed for stability, and then weight shifts when he was doing stepping or ambulation. He utilized a rolling walker for transfers and ambulation. but he was able to stand statically unsupported with close supervision for about 2 minutes without a loss of balance, and then he tolerated a maximum of 5 minutes of standing. Taking a look at the outcome measures that we used for this patient, at the day of initial evaluation, we took a look at the 5-time sit-to-stand Berg balance scale and the timed up and go. His 5-time sit-to-stand technically should have been scored a 0 because he used his arms. However, we took a look at the timing anyway, and it was significantly above the time for fall risk and his age predicted norm. His Berg balance scores, again, indicated a significant fall risk, and then his timed up and go score was above his age norm of about 8 seconds. Later on in his care, between, I'd say, about weeks 2 and 3 of a 4-week stay, this patient, we took a look at the 6-minute walk test, which he was significantly below his mean age distance, indicating decreased walking endurance, and his FGA at that time was actually above the predictor for falls, which was very interesting. We looked at the time up and go at initial evaluation based on it being a brief assessment of ambulation and falls risk, which we could also complete in his room as he was restricted to his room at that time due to COVID-19. And then we overall took a look at the 5-time sit-to-stand Berg balance scale, 6-minute walk test, and the FGA, as they are part of the core set of outcome measures put forth and recommended by the Academy of Neurologic Physical Therapy. So taking a look at my clinical impression and assessment of this patient after his initial evaluation. So again, this is a 62-year-old patient with a T8 AGD spinal cord injury and concurrent lung cancer and COVID-19, who's presenting to acute rehab with bilateral lower extremity weakness, altered lower extremity proprioception, impaired standing balance, and decreased endurance and activity tolerance, which is translating into activity limitations for all functional ability and participation restrictions, including visiting family and friends and being able to go dancing out. As far as environmental factors, his positives are the equipment and the home setup that he has, aside from steps to enter, and the support that he has from his sister and brother-in-law. As far as personal factors, this patient was motivated to return to independence. However, he had a negative outlook on inpatient rehab, and he specifically stated that his goal was to get walking on his own again so that he can leave inpatient rehab. Taking a look at the interventions for this patient, this is where I really struggled for this patient, actually. One of the main things that we worked on was dynamic balance activities. Things that we did included tandem and single leg stance, standing on compliant surfaces, balance during basketball, as that was actually a very salient activity for that patient and he really enjoyed it, so I tried to include it as much as I could. Ambulating over obstacle courses and ambulating with the FGA items, including head turns, eyes closed, and walking backwards. I struggled with this patient for dynamic balance activities in achieving an adequate intensity to these exercises to make sure that I'm hitting at that neuroplastic principle of intensity so that I'm challenging him to the point where I'm creating change in his balance. I really struggled at the beginning with this patient to be able to adequately challenge him prior to him being fatigued simply by doing an activity and simply by being up on his feet due to his decreased endurance and activity tolerance. That was something that my clinical instructor and I spent a lot of time discussing, actually, on how to jump up the challenge of the activity very quickly if I saw that it wasn't challenging, in order to not be then limited by his decreased endurance. So that was something that was much of a learning process for me, to be able to really challenge the patient, get adequate intensity, and get also salience in there when I could. And we also spent a lot of time doing endurance training throughout the sessions. It included trying to push him to increase time during the activities and taking on the activities prior to taking rest breaks, or taking standing rest breaks versus taking sitting rest breaks. We worked on increasing walking distances both with and without his single point cane, and we also utilized the upper extremity ergometer pretty frequently as a way to, again, work on cardiovascular endurance training to improve his pulmonary endurance after a point where we had fatigued his lower extremity muscles. Continuing to look at interventions, we spent a lot of time on functional mobility training. to really improve him to the independent level. This was utilizing that neuroplastic principle of specificity, really task-specific training for all functional mobility, and also as a way to improve functional lower extremity strength. There was a lot of strengthening thought behind these, including repeated sit-to-stands, again, ambulation with and without an assisted device, focusing on control and increased number of stairs, and also going up and down curbs. And then we spent a good decent amount of time on floor transfers to get functional lower extremity strengthening in those tall and half kneeling positions. And lastly, one of the biggest interventions that we took the time for with this patient was education. We spent a significant amount of time doing energy conservation education, including being mindful of the walking distance needed, being mindful of when to use his assisted device, when to use the transport chair, when to have the transport chair available, how to look out for sitting places when he's out in the community, how to ask for help, when to ask for help, and other strategies that he could use to help conserve his energy. Another thing that we spent a lot of time on was being mindful in how does he grade and scale his fatigue and activity tolerance, and we utilized the rated perceived exertion scale with him again, spent a lot of time going over that with him, and actually gave him a copy of that to go home with so that he could use during his day-to-day activities to monitor his activity tolerance and fatigue. And lastly, we really wanted to encourage him to continue to help increase his endurance after discharge. So we spent some time on appropriate cardiovascular exercise dosage and how to achieve that. As far as outcomes for this patient, he achieved a modified independent level for almost all functional mobility, aside for supervision for ambulating without his assisted device, contact guard assist for unlevel surfaces, and then supervision for curbs and car transfers as well, which was great. Really got this patient back to the independent level that he wanted. As far as outcome measures, he showed clinically significant improvements in functional lower extremity strength, balance, dynamic gait, and walking endurance for throughout the 5-time sit-to-stand, Berg balance scale, functional gait assessment, and 6-minute walk test. There was actually some variation in whether he fell above or below the falls risk category, but generally we could tell that he decreased his falls risk from his initial evaluation, which we were really thrilled to see the progress that he made. For discussion for the patient and the main takeaways that I took away from this patient case, one of the largest ones was that for patients that have endurance deficits for a variety of reasons, particularly it was complicated with this patient due to his other conditions at that time, particularly the lung cancer, it can be very difficult to achieve an appropriate intensity prior to simple fatigue of the whole body and decreased activity tolerance. I really struggled, as I talked about earlier, to achieve adequate challenge and adequate intensity for the activities that I wanted to complete that were not simply endurance activities. And so I really had to make sure that I was aware of how much I was challenging him, and could I achieve an adequate challenge in order to achieve change in the patient's balance and functional mobility prior to just him being tired from doing activities. Continuing with the thought of neuroplastic principles, I also spent a lot of time learning about specificity matters and salience matters. It was really important for me with this patient to get activities that would actually engage him and that he wanted to participate in order to make things a little bit better. The next takeaway point was that education can be a very, very powerful tool for these patients to better understand their condition and improve their quality of life upon discharge. I was really able to see the change in his behavior throughout his care and at discharge based on the education that we gave him on being mindful of his fatigue and his endurance levels. And we spent, again, a significant period of time on the education, and I really was able to show some change. So I hope to pass on that you are not forgetting the education part about patients' conditions and how to self-monitor and how to self-improve things. And lastly, I wanted to hit home that for patients with multiple active conditions, it's important to always remember the whole picture, how the other conditions are impacting their care, how the other conditions are impacting their ability to make progress, and how their conditions can impact their future mobility, and to make sure to discuss those things with the patient so that they are prepared for all outcomes. Thank you very much for your attention in this presentation. The following slides are my references.